Good evening, and thank you for joining DAVIC's very first Generation T2 webinar on planning for pregnancy. We're delighted to welcome Dr. Catherine Kibbe from Monash Health and Monash University to present the webinar for us. Just before we begin, we have a guest joining us, Amelia Lake, who is a researcher from the Australian Centre for Behavioural Research in Diabetes, and she would like to sit in on the presentation. If you have any objections to Amelia observing the webinar, then please type this into the chat box now, send it to us, and Amelia will withdraw from the presentation. Dr. Catherine Kibbe will be answering questions at the end of the presentation, so if you think of a question during the webinar, you can either type it into the chat box and select the Send to Staff option as you think of it, or jot the question down and submit it to us in the chat box at the end of the presentation. Now, I will hand over to Catherine, who will begin tonight's webinar. I hope you will enjoy it, and we will be happy to answer any questions that might arise after the presentation.
Good evening, everyone. So the topic for tonight is pregnancy and type 2 diabetes. So just to introduce myself, I work as an endocrinologist at Monash Health. I work at 3 separate sites. I work at Monash Medical Centre, I work at Dandenong Hospital, and I also work in Berwick. Sorry, we just got a little computer glitch. At Casey Hospital. I also work as the third year supervisor for Monash University medical students at Dandenong Hospital. I manage quite a lot of diabetes in pregnancy, and that's why this is such an interesting topic for me and hopefully for you also. So this is the outline of my presentation. I'm going to start by talking about a few statistics or fast facts about type 2 diabetes and also type 2 diabetes in pregnancy. Move on to talk about what actually is type 2 diabetes, then the risks of pregnancy in type 2 diabetes, then moving on to pregnancy quite specifically, so pregnancy planning, management of type 2 diabetes during pregnancy and also after pregnancy. At the end of the presentation, I would be delighted to answer any questions that you might have. So, some statistics. So, fast fact 1. 280 Australians develop type 2 diabetes every single day. Almost 1 million people have diabetes in Australia. The majority of that is type 2 diabetes. Between 2004 and 2005, $990 million was spent on treating diabetes. That $990 million was broken up pretty evenly between people who are in hospital as patients, outpatient medical services, and also prescriptions, the cost of prescriptions. My fast fact 4 is that of reproductive aged women, so aged 15 to 49, 53,600 have type 2 diabetes. That represents quite a large portion of that age group, so that's 1%. So between 2005 and 2007, type 2 diabetes featured in 0.3% of all pregnancies in Australia. If you have a look at this graph, it looks quite busy, but it's just actually to point out that ladies with type 2 diabetes, so this line here, if you can see my mouse, so pre-existing type 2 diabetes, are having their pregnancies a little bit later than ladies who have no diabetes in the open squares. One wonders if that's due to either problems with fertility, meaning that pregnancies happen later, or whether that's actually an active decision on the part of ladies with type 2 diabetes. In Australia, type 2 diabetes incidence is 10 times as high in those who have Aboriginal or Torres Strait Islander background. So after my fast facts, I'd just like to clarify what actually is type 2 diabetes. I have I see a lot of people who have type 2 diabetes, and it's amazing to me how little information is out there and easily accessible about exactly what it is. And sometimes it seems to me that people are hearing it for the very first time from me. So I just want to clarify that tonight. So I think the key is that diabetes is related to elevated blood glucose levels. In type 2 diabetes, it's due to a phenomenon called insulin resistance. And what that really means is that the insulin that you are making is not working particularly well. In addition, there is abnormal or even decreased insulin production, so the amount of insulin that your body is making is reduced. Insulin is made in cells called the beta cell in the pancreas, so we call that beta cell dysfunction. And this is the triple part of type 2 diabetes. There's an increase in liver glucose or sugar production. And I've got a nice little diagram here that hopefully the graphics will work on, just outlining those three elements to type 2 diabetes. So, here's a close-up of the pancreas. You can see that there are essentially two different types of cells. The yellow ones are the beta cells, and they're responsible for making insulin. The red ones are the alpha cells, and they're responsible for making a hormone called glucagon. Over time, with type 2 diabetes, this beta cell produces less insulin, and the alpha cells produce too much glucagon. Extra glucagon tells the liver to make sugar, which results in too much sugar production and elevated blood sugars in the blood. It's over in the muscle and fat that the insulin resistance has its part to play. With decreased glucose uptake from the blood, as well as a reduction in insulin over time, the muscle and the fat do result in changes with the muscle and the fat result in hyperglycemia as well. So you can see it's almost a three-stage process. I think it's really important to remember that insulin resistance, the main part of insulin resistance, is actually genetic. In the media, you hear a lot about type 2 diabetes being caused by lifestyle, and I think that there is a lot of blame put on people who have type 2 diabetes that is completely incorrect. The genetics of somebody have a huge part to play in whether someone is resistant to insulin or whether they are not. If you have a look at this graph, irrespective of somebody's body weight, if you have a family history of type 2 diabetes, your body is less sensitive to insulin. This results in higher blood sugars and an increased chance of type 2 diabetes. Of course, there are environmental aspects to insulin resistance, and being overweight or obese certainly has a part to play here. Over time, you get a reduction in the number of insulin-making cells in the pancreas, which causes a reduction in insulin secretion. And a key part about type 2 diabetes is that this process may begin even a decade before the diabetes is actually diagnosed. If you have a look here, you can see over time, this bright blue line, you can see over time the amount of insulin that is actually made reduces. And this is part of the reason why most people with type 2 diabetes eventually will need some insulin. The key point about type 2 diabetes is that it does not stay the same. It changes over time. The increased liver glucose production is as a result of the decreased ability of glucose and insulin to reduce glucagon production. And this is often why when you check your blood glucose level before breakfast, your sugar is higher in the morning than before you actually went to sleep. So this is often a direct result of too much glucose being produced from the liver. And this is just illustrating the fact that the bottom line is someone without diabetes, and the top line is someone who has type 2 diabetes. So not surprisingly, the blood glucose level is higher, as is the glucagon level. It almost directly mirrors the blood glucose. So what are the risk factors for type 2 diabetes? So I've mentioned family history of diabetes. It's the chance of having type 2 diabetes is 2 to 3 times, at least 2 to 3 times higher if you have a first degree relative with type 2 diabetes. So I'm talking about a father or a mother, for example. And this is probably a combination of the genetics that I've already mentioned, as well as lifestyle reasons. So when you're in a family, there's a lot of learning behaviour that goes on, particularly as a child. So if it's a family that perhaps doesn't exercise so much or has a potentially slightly unhealthy diet, that's learnt and then potentially can continue on. Ethnic background has a huge part to play, and an increasingly huge part to play in type 2 diabetes and why people do or do not get it. This is just one study, and it's an American study, so the ethnic mix in this study is a little different to Australia, but we know that people from Southeast Asia have a 2.26 times higher chance of type 2 diabetes than a Caucasian person. Hispanic, 1.86 times higher, and those of African American background, 1.36 times higher chance of having diabetes, again, when compared to a Caucasian population. In Australia, we see a much higher incidence of type 2 diabetes in people from the Indian subcontinent. So India, Sri Lanka have a much higher incidence of type 2 diabetes, and that is most likely due to genetic factors. How about obesity? Well, you can see here that as the body mass index increases, the rate of type 2 diabetes increases. I have deliberately included this slide to be almost around the normal. So 24 to 25.9 and a body mass index of over 26, that's just in the overweight range. So even on those upper limits, extra body weight can certainly increase the rate of type 2 diabetes. It's not just obesity or increased body weight that's the issue, it's where the body weight sits. So upper body obesity in this graph is talking to weight or extra fat that's sitting around the tummy. Lower body obesity is extra weight that's sitting around the hips. So often ladies, their extra weight sits around the hips and the bottom. This is interesting. The birth weight of babies, both if it's a low birth weight baby or a high birth weight baby, does seem to influence the incidence of type 2 diabetes in that individual. So it's what we call a U-shaped curve. So a higher incidence if the birth weight is very low, and also a higher incidence of type 2 diabetes if the birth weight is very high. Lifestyle factors such as how much exercise a person gets, whether they smoke cigarettes, even things like sleep duration. So if you have not enough sleep or if you have too much sleep can also influence your incidence of type 2 diabetes, and it appears that a Western diet also influences this. This is an entire talk by itself, the polycystic ovarian syndrome or PCOS, but it is certainly associated with a higher incidence of type 2 diabetes in ladies who have PCOS. So what are the risks of pregnancy in type 2 diabetes? Well, there are risks to both the baby and risks to the mother.
Yellow.
So, talking about the risks for the fetus or the baby, We know that ladies who have type 2 diabetes in pregnancy have a higher rate of stillbirth, a higher rate of miscarriage. There is a higher rate of congenital malformations, and those malformations generally involve the spine, heart, and the kidneys. There's also an increased rate of resuscitation of babies born from mothers who have type 2 diabetes, and a higher rate of intensive care admissions for the babies. Babies born of mums who have type 2 diabetes have a higher birth weight than mums who do not have type 2 diabetes. And these babies also have lower blood glucose levels than babies born to mums who do not have type 2 diabetes. How about the risks for the mother? We know that there's a higher rate of high blood pressure or hypertension, and also preeclampsia, which is high blood pressure and protein changes that occur later in pregnancy. There is a higher rate of preterm birth, so birth that is less than 37 weeks gestation. And if you have a look at this graph, you can see here that those with pre-existing type 2 diabetes have a higher rate of preterm birth than those with gestational diabetes in pregnancy and those who do not have diabetes in pregnancy. The rate in ladies with type 2 diabetes is 13% versus 4% of those who have no diabetes in their pregnancy. There's a higher rate of induced labour and a higher rate of caesarean section in ladies with type 2 diabetes. When you compare two groups, the incidence of induced labour or caesarean section is 49% in those with type 2 diabetes and compared to 20% in those who do not have diabetes in their pregnancy. Importantly for ladies with type 2 diabetes is that in ladies with type 2 diabetes, there's a higher rate of first appearance of diabetes complications, and worryingly, particularly for ladies and also clinicians, there's an increased progression of diabetes-related kidney and eye disease during pregnancy. Now, after telling you all of that slightly terrifying information, I'd like to point out that these risks are related to high blood sugars during pregnancy, both slightly before conception and during the first trimester, obviously, and throughout the pregnancy. But in terms of things like fetal malformations, etc., it's that first trimester that's incredibly important. So, this is why pregnancy planning is absolutely essential. It needs to be undertaken, that pregnancy planning and management through pregnancy by a multidisciplinary team who are actually experienced in managing diabetes during pregnancy. Pre-pregnancy counselling is incredibly important so that ladies are aware of the potential problems that can occur if a pregnancy is unplanned and the blood glucose levels are poorly controlled. A NICE study had a look at pre-pregnancy counselling and found that there was a lower chance of congenital or birth abnormalities in those who were attending a counselling session before falling pregnant. I think it's always important to remember that the general advice for all ladies, such as stopping smoking, reducing alcohol intake, reviewing all medications and vitamins for safety in pregnancy, making sure that immunisations are up to date. Weight management is incredibly important in all Australian ladies. We know that our women in Australia are on average putting on about 0.5 kilogram per year of weight. That's all ladies, not just ladies with type 2 diabetes. So ensuring that weight is controlled and potentially weight is lost before pregnancy is a really important part of a pre-pregnancy management plan. Contraception is really important until pregnancy is actually desired, and also until the green light is given for pregnancy by clinicians. We now know that folic acid at 5 milligrams a day is an important part of pre-pregnancy planning for optimum development of the baby, particularly in the first trimester of pregnancy. And I always like to make sure that thyroid function is checked because it's such an easy thing to fix if it's abnormal. How about diabetes-specific advice pre-pregnancy? So I emphasize again that good blood glucose control before falling pregnant is really important. The target for HbA1c is a little bit controversial. So generally, in a non-pregnant lady with type 2 diabetes who's had it for some years, the HbA1c of less than 7% is entirely appropriate. There is increasing evidence that aiming for an HbA1c of less than 6.1%, so heading towards the normal range, improves outcomes in type 2 diabetes during pregnancy. I just want to highlight some of the diabetes medications that we do use. So some ladies with type 2 diabetes are taking insulin. The human insulins are all safe during pregnancy. And the insulins, and I'll use brand names, Humalog and NovaRapid, have a category A listing during pregnancy. So there are no worries about fetal problems during pregnancy on these medications. Newer insulin analogues or newer types of insulin, such as Lantus and Levemir, which are commonly prescribed, don't have a category A rating in pregnancy. However, we do use these often in pregnancy because having good blood sugar control is actually the most important factor. In general, diabetes tablets are ceased before pregnancy is attempted. The reason for this is that some diabetes tablets are unsafe during pregnancy. Metformin is a medication that is first line for ladies and gentlemen with type 2 diabetes, and it's a fantastic tablet for controlling blood sugars. And often the risks of stopping metformin are greater than potential risks of continuing. So many women with type 2 diabetes will actually continue with metformin therapy for certainly the first trimester, but often for all of their pregnancies. The evidence for safety of metformin during pregnancy is mounting. Some ladies with type 2 diabetes are taking blood pressure or kidney tablets to protect their kidneys prior to pregnancy, and often these need to be changed to a safe option before pregnancy occurs. That's something that's very important to discuss with your treating clinician. Cholesterol medications must be ceased before pregnancy. And it's really wise and prudent, and certainly part of my management, that all ladies with type 2 diabetes, before they fall pregnant, should have a proper complication screen looking at their eyes, their feet and their kidneys, so that we're well informed and can plan for their pregnancy so that it's a nice safe outcome for everybody. I mean mum and baby. So how about during pregnancy? I've mentioned the multidisciplinary team. So who do I mean? So I mean the obstetrician, an endocrinologist, or perhaps a physician who's experienced in diabetes care during pregnancy. Diabetes educator is an absolutely critical part of the team, as is a dietitian. I think it's important to remember that in some areas of Australia, this is not always possible. So if someone is living in a more regional centre, often their general practitioner and their obstetrician are highly skilled in managing diabetes and often can be beautifully managed during their pregnancy. However, often expert advice is needed. Review for diabetes tends to occur between every 1 to 4 weeks until week 30 of the pregnancy, then every 2 weeks, and during later stages, often every week. This varies considerably. I think what is definitely true and almost universal is that touching base with either your endocrinologist or your diabetes educator on a weekly basis whilst pregnant is pretty much mandatory for ladies with type 2 diabetes to ensure the best outcome. Generally, not universally, but generally ladies will need insulin. An important point is that if someone goes into pregnancy with diet-controlled type 2 diabetes, insulin may only be required in the later stages of pregnancy. A key point here is that the pregnancy hormones increase the insulin resistance of type 2 diabetes, making it even more difficult for the body's own insulin to work. What is crucial and essential during pregnancy is that blood glucose levels must be monitored. These targets are a little controversial, but I'm giving you what we currently do at Monash Medical Centre. So we aim for a fasting sugar of under 5.5 every day, and 2 hours after meals we aim for readings less than 7. Some hospitals are aiming for less than 5.1 and 2-hour meals less than 6.7. Slightly controversial, but I think the key point here is very tight blood sugar control. An HbA1c is performed every 4 to 8 weeks with the understanding that it's not necessarily reliable completely during pregnancy, but it certainly gives a guide as to how things are going. Insulin requirements can fluctuate during pregnancy, so we often find that the doses are a little bit lower during the first trimester, then they increase, and at 32 weeks in some ladies, insulin doses can actually drop. We aim to avoid hypoglycemia or low blood sugars. In terms of complication screening, we certainly perform regular kidney review, and ladies are required to have, or we suggest they have, 3 monthly eye review if they have underlying diabetes eye problems or retinopathy. If, for example, they go into pregnancy with very high blood sugar levels, and these are rapidly improved during pregnancy, it's important to have regular eye checks, and also in ladies who have quite long-standing diabetes. Now, lifestyle measures are really important, and that's one of the reasons why the dietitian is such a key part of this multidisciplinary team. So making sure that lots of fruit, lots of vegetables, or rather appropriate amounts of fruit and appropriate amounts of vegetables, less saturated fat. So essentially a healthy diet is really important. I've put a slide here quite deliberately of ladies walking when talking about exercise, because I think people seem to think that exercise requires you to be running on a treadmill or going on a stepping machine. I think that walking is perfectly adequate exercise, and certainly during pregnancy in the later stages it's often what can be accomplished because you've got a big tummy and things can get quite uncomfortable. Walking does not have to happen outside. If it is raining or cold, you can walk around your lounge room for 20 minutes a day with no problems at all. So sadly in my clinic there's a no excuses rule for exercise. Oh, and may I add that those rules of healthy lifestyle, diet and exercise don't just apply to ladies with type 2 diabetes. Again, I reinforce, they apply to the entire Australian population. Just a little heads up, during labour, your blood glucose levels will be regularly monitored. You may need insulin during labour, and that does vary depending on what the blood glucose levels are and things such as insulin dose leading up to labour. So how about post-pregnancy? So when you have a new baby and everything's gone beautifully, sometimes diabetes takes a back seat, which is why having a diabetes appointment scheduled for 1 to 2 months after delivery is really important. Often, if you're started on insulin during pregnancy, this can be ceased at your after pregnancy appointment. For ladies who are not breastfeeding, they can potentially recommence their diabetes tablets. But if you're breastfeeding, we still generally recommend that insulin is continued until breastfeeding stops. Contraception is really important. Just because you're breastfeeding doesn't mean you can't get pregnant. I think a lot of ladies have come across that issue. And once again, continuing with exercise is really, really essential after pregnancy. And I'm going to pause and see if anybody's got any questions. Well, pause it, rather finish, and see if anybody has any questions. I'm sorry if there were audio problems earlier on. Much for listening. If you do have questions that come up in the next couple of days, please email them through. No problems. I'm just going to pass back over to Angela.
Hello, and apologies from us for any technical glitches may have occurred. We will hopefully have the webinar recorded. So if you had difficulties with the sound, please email me and I will get a copy of that to you over the next couple of days. Thank you very much for attending this, our first webinar, and for bearing with us over the technical glitches. As Catherine said, also if you have any questions, email them through to me and I will be able to respond. I'll liaise with Catherine and respond to those. Hope you enjoyed it, and also please contact me if there's any other topics that you think we should feature in future webinars. Thank you and good night.